Hillary and I are very excited to talk with you today about some of our work leveraging VA text note data for quality measurement, a case study of a novel measurement tool for cardiac device procedures. We hope that we are able to take you on a journey from why we sort of embarked on this study, and then where we are and how we hope to translate it ultimately into clinical practice. Before we get started, just a couple disclosures. I am the site PI of a study funded by Gilead Pharmaceuticals with funds coming to the institution. This study is evaluating the impact of outpatient remdesivir on early mild COVID disease, and is not directly related to the topics we're presenting today. I'm also a consultant for DLA Piper, and this study has been funded by many funding organizations, including VA EHR, the NIH, NHLBI, and the American Heart Association. So before we move forward, we'd like to start with our first poll question, and that is, what is your primary role today? We'd love to hear a little bit about who is in the audience. So we'll give you about a minute to respond.
And that poll is open, Westyn. Once again, as everybody knows, the question is, what is your primary role? Answer options are student, trainee, or fellow, VA clinician, non-VA clinician, VA researcher, non-VA researcher, programmer, administrator, manager, or policymaker, or other. And if you like, you could send a chat to me telling me what other means to you. And if there's time, I can read those off to our presenters. But right now it looks like things are slowing down a little bit. I'll leave it open just a tiny bit longer. And I'll go ahead and close the poll now. And I'll read off the results. What we have is that 6% answered A. Bear with me while I make my view a little bit wider. And another 6% answered B, 0% answered C, a whopping 44% answered D, who are VA researchers, 9% non-VA researchers, 22% programmers, 3% administrator, manager, or policymaker, and 6% other, and one person wrote in that they are a quality professional /RN. So I'll go ahead and close the poll, but we can move forward with your slides at any time.
Excellent. And we have tried to design this talk to be as of broad interest as possible, but please, if you do have questions as we go along, Hillary and I we arranged for time at the end to answer them, so please put them in the question box, and we will hopefully be able to answer your questions to the best of our ability. Our roadmap for the next hour or so. First, I'm going to go over the role of antimicrobials in preventing infection and reducing harm, and when they are appropriate and when they aren't appropriate, and what the guidelines say about when we should be giving antibiotics before a surgery or before a procedure. I'm going to talk a little bit about the Surgical Care Improvement Project and some of the successes and limitations of the program and where it got us and where we can go from here, as well as highlight some of the challenges of stewardship in non-traditional surgeries and in procedural care. I'm then going to touch upon some information about cardiac device procedures performed in the electrophysiology lab specifically. In particular, I'm going to talk about the need for improved antimicrobial stewardship in this area, including highlighting some VA data about post-procedural antimicrobial use and some of the harms associated with antimicrobial use. I'm then going to go into some of the challenges that have been encountered in the electrophysiology lab, in particular measuring infections and antimicrobials, both pre and post-operative data. I'm then going to hand it over to my colleague, Hillary Mull, who will talk about how we can integrate TIU notes to solve some of these measurement challenges. And then we will go into some of the implementation factors, including factors that have driven behavior, and how we're going to map some of these barriers to implementation strategies to try to improve practice in the future. We'll then touch upon some future directions and open it up to a question and answer. So first, starting with the Surgical Care Improvement Project, and in particular, I'm going to highlight the infection metrics that were included as part of the surgical care improvement project. So it's important to distinguish when we're thinking about skip and pre-incisional antimicrobials when antibiotics are given. There are a couple evidence-based and guideline-recommended practices. In particular, it is highly recommended and highly evidence-based that antibiotics be administered within 1 hour prior to skin incision. The reason we do this is the idea is that we want to get antibiotics to a sufficient level in the bloodstream before the incision so that the antibiotics are present and can help the immune system clear up any bacteria that may be introduced during the skin incision and during the procedure. But it's important that these antibiotics be given before the skin incision and not after the skin incision, because many studies have demonstrated that antibiotics given after incision do not reduce incidence of infections, but they do actually increase the risk of other adverse events, such as C. difficile infections and acute kidney injuries. So the two key evidence-based and guideline-recommended practices are, one, to give patients antibiotics within 1 hour prior to skin incision, and two, to stop antibiotics within 24 hours after skin incision, and ideally to stop them immediately after the procedure. And so because of the strong evidence basis for these recommendations, when the National SCIP program was rolled out, it included 3 key infection measurement metrics. And this included SCIP-INF1, which was prophylactic antibiotic received within 1 hour prior to surgery. INF2 related to the appropriateness of that antibiotic. They wanted to make sure that the antibiotic matched the part of the body where the surgery was occurring. So they wanted to make sure that not only were we giving antibiotics in the right time, but we were also picking the antibiotics that matched the likely organisms that might cause an infection after surgery. And then SCIP-INF3 was discontinuation of antibiotics within 24 hours of skin closure, or they did allow for up to 48 hours after cardiac surgery. These metrics were part of a much larger surgical quality improvement program, which included many quality measurement factors. But critical to this is that these variables were measured within the VA using as part of the EPRP program and using manual review. The Surgical Care Improvement Project was highly successful in the places it was implemented. So the Surgical Care Improvement Program primarily targeted major inpatient surgeries such as neurosurgeries, orthopedic total joint replacements, and cardiac surgeries. Almost all of the SCIP metrics covered the major surgeries. However, other parts of the SCIP program were more limited, and SCIP-INF3 in particular did not target minor procedures and outpatient surgeries. So over time, the SCIP program was found to be highly successful. And within the VA, we found greater than 97% compliance with postoperative metrics, and greater than 97% compliance with the antimicrobial use metrics. We also found an improvement in process measures, such as a reduction in postoperative antimicrobial use. And we found that these process measures were associated with a simultaneous decrease in postoperative adverse events, including surgical site infections. So I just want to highlight that we found that a reduction in antimicrobial use was associated with also a simultaneous reduction in the incidence of surgical site infections, again indicating that it's really safe to stop antibiotics after the procedure. This program, however, was fairly time intensive. As I say, it was based on a manual review by a trained nurse chart reviewer. And so due to the high cost of the program, as well as the consistently high levels of compliance, the program was sunsetted in 2015. And so since then, we haven't had a big picture of 2 things. One, we don't know a lot about what happened to the sustainability program after it was sunsetted in 2015. And 2, there are outstanding questions about how well the program diffused to surgeries and procedures that were not included under its umbrella. And remember, the program really targeted major surgeries rather than minor surgeries. and it did not target outpatient or procedures with INF3, including notably the electrophysiology lab and cardiac device procedures. So what happened? This is a question that our group has been pursuing for several years now, looking at how well some of these practices diffuse to other areas. So these are some data from outpatient surgeries, and you'll notice that some of these outpatient surgeries do include surgical specialties that were at least partially covered under SCIP, but this tends to represent more limited and more minor procedures. So for example, in orthopedics, it might include arthroscopic procedures, but probably does not include major hip replacement. And so you can see this is looking at the percentage of surgeries within the VA with post-operative antibiotic use. And so remember, we want to give antibiotics preoperatively, but we do not want to give them post-operatively. And what we found among this outpatient surgery population is that antimicrobial use following the procedure was very low in eye surgeries, and we sort of selected eye surgeries as a control group just to figure out what the background rate of antimicrobial use might be. Antibiotics don't penetrate the eye very well, and so if you're giving antibiotics, typically it wouldn't be for prophylaxis if you're doing an eye procedure. And you can see that for general surgeries, which were partially covered under SCIP on the inpatient side, there was a very low rate of post-operative antibiotic use. Similarly, there was a fairly low rate with orthopedics, but substantially higher than general surgery. And we found very high rates of post-operative antibiotic use among GU and ENT procedures, neither of which were covered under the broader umbrella of inpatient SCIP. So we also looked at this question. So we looked at some general surgeries and surgical specialties. We also then began to broaden our scope to look at procedural specialties that are not trained in traditional surgeries. And so our question was what was happening in the cardiac device lab or the electrophysiology lab. And what we found was that these cardiac device procedures, which again were not covered under SCIP, had very high rates of post-operative antimicrobial use. And in fact, the median duration in the VA is approximately 5 days, and the most commonly prescribed agent is cefalexin. In addition, although it's not shown on the slide, we also found that the increasing use of post-operative antibiotics in this population was associated with increased rates of acute kidney injuries and C. difficile infections, including several C. difficile infections in which the antimicrobial prophylaxis was the patient's only antibiotic, and in which the patient ultimately went on to die from their C. difficile infection. And so I tell you that to highlight how important it is that we find a way to improve antimicrobial use following procedures. We also found substantial variation in substantial facility level variation in practice. This is looking at how the antimicrobial use was distributed, the post-procedure antimicrobial use was distributed across many different VA facilities. And what you can see is that there are some facilities that are prescribing antimicrobial prophylaxis almost 100% of the time, some that are prescribing it almost never, and then a lot of procedures a lot of facilities in the middle. So all of these studies were based on post-procedural antibiotic use. And so post-procedural antibiotic use in the VA is relatively simple to measure because we can simply measure orders and administrative and dispensed pharmacy data. However, while post-procedural use is very easy to measure, what about pre-procedural use? So one of the first things I said was that giving pre-incisional antibiotics is a highly evidence-based practice and one that we want to encourage and ensure occurs. Pre-incisional antibiotics are strongly recommended in the guidelines, whereas post-procedural antibiotics are not. But the post-procedural antibiotics are very easy to measure because we have large VA pharmacy databases. Preoperative antibiotics, however, are more challenging. Because these antibiotics are often dispensed directly from the Pyxis in the EP lab, oftentimes there's no order generated. There's no dispensing record in the EMR that can be easily measured. And so oftentimes, the only documentation of pre-procedural antibiotics is in text notes. And that can include procedure notes and anesthesia records, either of which can be in the form of as an EMR note, or unfortunately also as a scanned-in paper record, which is even more challenging to access. So in summary, we found several management challenges that we needed to overcome in order to look at this question of guideline concordance and how we might ultimately begin to develop a system for measuring and hopefully improving antimicrobial use in non-traditional areas. So some of the challenges that we encountered are: one, outpatient and procedural specialties are exempted from SCIP INF3, that's the early post-procedural discontinuation metric. And what we have demonstrated is that INF3 unfortunately did not diffuse out from the inpatient hospital very well. Perioperative antimicrobial use does not always require an order, so it can be hard to find and hard to measure. And often administration is not documented anywhere, including in barcoding or medication administration data. And so reliance on structured data only misses a large proportion of cases where guideline concordant care was administered. Administration is often documented in clinical notes, such as the operative note or the anesthesia records. However, this is text note unstructured data, and so it is not as easily searched or identified. So how do we begin to address some of these challenges? So the first thing I would like you to do is to introduce you to a couple of cohorts to explain our methodology and how we began to tackle this problem. So there's a national VA EP cohort, which includes all of the patients that underwent electrophysiology procedures in the VA during the time period, and that's around 15,000 patients. However, a subset of these patients were entered into what is called the VA Clinical Assessment Reporting and Tracking Program, CART, or VA CART. VA CART is a national initiative for tracking complications following cardiac procedures. Entry is mandatory for cardiac catheterizations, but it's voluntary for EP and cardiac device procedures into this kind of subset of CART called CART EP. And as part of a previous study, we knew that about 14% of device procedures are entered into CART. And we had actually had data on manually reviewed data on all of the CART EP procedures. And so all of those procedures underwent manual review by a trained clinician for pre-procedure antimicrobial use, post-procedure antimicrobial use, 90-day presence of infection. So we had all of that data manually reviewed in this subset of cases. Which brings us to our second poll question. What is your familiarity with TIU notes? I've never heard of them before. I've heard of them, but I have not used them, and I'm only somewhat familiar with them. I'm interested in using them for a research study. I'm interested in using them for operations. I'm already using them, and I'm very familiar with others. So I'll give you guys a minute to answer.
Dr. Branch-Elliman, that poll question is open, and people are submitting their answers quickly. I think we can just leave it open for maybe another 10, 15 seconds. Although it does look like it's leveling off quickly, so I'm going to go ahead and close the poll at this time and share the results. And then I'll read them off to you. 18% answered A, never heard of them before. 42%, the largest number, say that they've heard of them but not used them or somewhat familiar. 21% say that they are interested in using them for a research study. Nobody said that they're interested in for operations. 18% say that they're already using them, and nobody answered other. And so, anytime.
Thank you. So how did we go about addressing some of these questions? Our first step was to develop a new methodology for measuring peri-procedure prophylaxis. And in order to move to expand beyond the traditional SCIP program, we combined structured and unstructured data to measure peri-procedural prophylaxis. And by peri-procedural prophylaxis, I mean prophylaxis both before and after the procedure. And so we did this by leveraging that already manually reviewed CART-EP data set, and then iteratively testing structured and unstructured text data to look for documentation of antimicrobial administration. So within structured data, we were looking for antibiotic orders and dispensing data, and within the unstructured text data, we were looking for documentation of antimicrobial administration from clinical notes. We then, after we had developed some preliminary text strings and searches, we tested the algorithm on all cardiac devices, the larger EP cohort, performed within the VA healthcare system during the period from fiscal year 2016 to 2017. And then we sampled a small subset of the cases with both positive and negative flags to confirm results and to identify reasons for discordance. So how did we do this? First, we generated a list of relevant antimicrobial names, and this included both generic and commercial names. And that was important, especially as we moved into the TIU note searches, because while the structured pharmacy data is structured with the generic names, the commercial names are often used in clinical notes. For example, it's very common for a clinician to write Keflex instead of Keflexin, and so it was important that we included both generic and commercial names for the TIU note searches. We then used wildcard searches applied to TIU notes to measure antimicrobial use based on identification of antimicrobial names in those TIU notes. And we allowed for inversions and spelling mistakes and other small errors in order to improve capture. We also restricted our searches based on clinical note title, note document type, and note entry date. So we did not want notes that were a year away from the time of the procedure. We wanted to make sure we were getting appropriate notes where we would expect to see prophylaxis, things like that. We then conducted several rounds of testing, including looking at different time windows for orders, note types, and type of antimicrobial. For example, we looked at only including intravenous antibiotics, only including some oral but not all oral, those sorts of questions. And then we reviewed cases for reasons for discordance and classified those reasons for discordance qualitatively. So what did we find? These were some of the data elements that we included in our algorithm for measurement. These included text note searches, antimicrobial orders, antimicrobial administration, and then various combinations of different strategies. So text note searches and orders, or text note searches, administration data, just orders administration without text notes, or some combination of the three. After we completed our first round, we then limited our data set in various ways to try to optimize it. And so some key points that I would like you to take away from these data. Number one is that text note searches and orders alone miss a substantial number of true antibiotic administrations. So you see, if we look at text note searches and orders alone, we get about a 90% hit, or each one gives us about a 90% hit. But we knew from our data that there was appropriate antimicrobial use in around 98% of cases. So we knew we were missing a bunch when we used either one of these strategies alone. When we combine text note searches and orders, we substantially increased the positive and negative predictive value, but we actually found no additional benefit to adding administrative data. And that was because for every single administration, there was also an order. And so we didn't get any additional bang for our buck by adding the administrative data, but it did require more programming and program running time. So it ended up being fairly inefficient for not increasing the predictive value of our algorithm at all. We found that the optimal, so the text note order searches and the with it or without administration, you'll see that the numbers are exactly the same. During round two, in order to improve optimization, we tried a variety of different strategies, including excluding oral medications, limiting our list to commonly used prophylactic medications, excluding notes from the day of the procedure, and including the general term prophylaxis in our text note searches. What we found was the general term prophylaxis was not helpful at all. It just kind of increased noise, so we did not end up pursuing that strategy. But we did find that limiting our list to more commonly used prophylactic medications optimized algorithm operating characteristics. This is a comparison of algorithm accuracy to the manually reviewed cases from CART. And as you can see that for the vast majority of facilities in CART, the algorithm performed very well. There were a couple facilities where we did find some disagreements, both positively and negatively, and I'll get back to that in a second. But overall, we found an excellent rate of agreement and very promising results for leveraging this algorithm to measure appropriate antimicrobial use. So where were the problems? There were a couple of documentation practices that drove false positives and false negatives. At some facilities, we found that standard practice was to record antimicrobial administration in only handwritten notes. And this led to complete algorithm failure at these facilities. So in every one of these cases, the algorithm had said that no antimicrobial prophylaxis was used, when in fact it was used in almost every case. And that's because we do not have a good method for measuring handwritten notes. However, as the electronic medical record continues to evolve and more facilities move to electronic notes, including for anesthesia, we are hoping that this challenge will be reduced in the future. Other reasons for false negatives included lack of antimicrobial name documented. So, for example, the provider simply wrote prophylaxis given without further specifying what the prophylaxis was. And other rare occurrences, such as strange things that happened, such as a case was canceled, so there was maybe an order generated or documentation that the prophylaxis order was placed, but then the procedure was scheduled for a much later date, 5 or 6 months down the line. And so the case and the documentation were too far apart for the algorithm to link them. False positives in this, in our false positives identified by the algorithm were primarily due to post-procedural antibiotics documented in clinical notes, and this seemed to be a facility-specific practice. So at the end of the procedure note, the facility would write, please give 3 doses of cefazolin post-op. And because cefazolin was documented in the operative note, the algorithm read that as appropriate prophylaxis, when in fact it was a false positive and the prophylaxis was given after the procedure. We found that combined text notes and structured data can be used with high levels of accuracy at most facilities. So the previous graph I showed you was looking at the performance among the CART data set. This is among the entire national cohort. And what we found was many facilities had excellent compliance with appropriate preoperative antibiotics. Some facilities, however, did look like some improvements were needed with compliance in the 60 to 80% range. And some of the facilities had very low rates to the point where, and many of these facilities are the ones that have problems, for example, with documentation and handwritten scanned in notes that the algorithm simply does not work at. Or a standard practice at some of these facilities is to write antimicrobial prophylaxis given, but not to specify the type. And the algorithm wasn't designed to measure those cases. So to some extent, measuring antibiotics is easy. We have a defined list of antibiotics that we want to look at. It's a relatively short list in the grand scheme of things. It's clearly defined than medications. What about infections? Infections are a much harder outcome because they're complicated. It's even complicated to come up with a standardized definition, let alone figure out how to take a standardized definition with known limitations and translate that into an electronic algorithm. And one of the challenges that we have found in electronic surveillance of infections is that there are limitations to using structured data searches for measuring healthcare-associated infections. And this phenomenon has been demonstrated in many different settings. And why is that? It's because if we think about diagnostic and therapeutic pathways, oftentimes they're sort of overlapping and not clear. But thinking through what happens when somebody has a suspected infection and a diagnosed infection can be helpful as we think about what structured variables might be useful and why some structured variables we think they might be useful, but it turns out that they're not actually all that predictive. So I'm just going to walk you quickly through what happens when somebody comes in with a suspected cardiac device infection. So somebody comes in, they maybe have pain at their pacemaker site, or they have fever, or signs of systemic infection. At that point, they may get some consultants, in particular an infectious disease consultant. They're likely to get some imaging results, and hopefully they'll get they'll hopefully get a microbiology order, such as a blood culture order or a wound culture order. From then, they may or may not go on to have a positive imaging result or a positive microbiology result. And then if they get a positive micro result, you will get a probable pathogen cultured and then targeted antibiotic therapy. So what we're really looking at is we have some imaging and diagnostics, and then we have some therapeutics. It's also the case in many cases, they'll have a repeat procedure either to remove the device or to clean the device. And so these are sort of the places that we can look in the structured data to see if we can find infections. Some challenges that have been found in other areas are that ICD-9 and 10 codes may be specific, but they're not very sensitive. And antimicrobials are of limited predictive value due to their very frequent use. And so this is another way of showing some of the challenges. This is from the CART-EP data set, which had approximately 101 infections. And you can see the infections are in this red circle. So, and then this is sort of a Venn diagram of all the structured variables that we can look at for trying to find infections. And as you can see, we had 94 infections, so 94 people with an infection got an antibiotic, but 880 people total got an antibiotic. So that means 42% of the entire population had an antibiotic. So that variable alone just doesn't have a lot of discriminatory power. Similarly, we find that lots of patients had micro orders, but not that many of those micro orders actually translated into a cardiac device infection. And then positive cultures and billing codes, there were fewer cases, but we still missed a lot of the true infections. So what can we do to solve this problem, and how can we improve upon the structured data to try to measure infections electronically? So the next steps include integrating data from clinical text notes to improve infection detection. And at this point, I'm going to hand it over to Hillary to talk about the next part of this, which integrated the complicated piece of the TIU notes for surveillance. Hillary?
Thank you. Rob, did you make me the host?
I just did, and it should be active now.
Okay. All right. Thank you. So before I continue, I just want to answer one question that showed up in the comments because, or in the Q&A, because I do think it's relevant. So the question was, what kind of data are in the TIU note? That format is in the VA's corporate data warehouse in a table, and it is just a bunch of words. It's just one row for each clinical note. There are some descriptors of the note name, and then there's just the content, the report note itself. And so there, it's just a very, very, very long field of note data. So you could potentially extract it into a CSV file. You can download it into SAS in some ways, but a lot of those different ways of storing data have limits on the amount of information you can have in the cell. So that typically when we do this kind of work, we use SQL and do keyword searches and then flag those records. And then we go and look at the clinical note ourselves with chart review, which is a very different presentation of the same text information. So I hope that answers that question. Okay, so as Westyn said, what we wanted to do is improve upon the work that we had done with the CART data set by integrating the information we could find from the clinical notes to try to improve the precision of our searches. Again, we knew that there were going to be problems from the notes. We knew that there was going to be issues with how the clinical notes were unstructured, that they would vary across facilities, and we knew that from our work with the antibiotics. And we also thought there would be sort of facility, maybe regional, maybe provider level variation in how information was documented. And then probably our biggest concern was this issue of notes that have sort of copied forward information where they always store the same information in every note about prior patient utilization. So if they had a diagnosis 4 months ago, that diagnosis just keeps showing up on every single note. So we set about this task of improving our detection of infections after, and we're using CIED everywhere, but I don't think we defined it yet. So let me just say that's a cardiovascular implantable electronic device. We're calling it a cardiac device that's performed in an electrophysiology lab, but just to be clear what the CIED acronym is that's here. What we wanted to do was start with the CART data again, because that is sort of a gold standard since it's got chart reviewed information in it. We wanted to start there with a set of information that we could map to the corporate data warehouse and find those patients' TIU notes. And then we would know the people who had an infection or not, and we could start creating these different TIU note flags. So the first thing is the clinical diagnostic therapeutic pathways and the billing and procedure codes. All of that was described in the last section that Westyn just went over. Again, the flags and the algorithm that we had used before, apply that again. And then we will find these flags that have a high negative predictive value. So our goal was to get the subset of the CART data that had the highest likelihood of an actual infection. And then we took all those flags and we applied it to everybody who had a cardiac device placed in fiscal years 16 and 17. And we split our sample in half. So we had a development sample and we had a validation sample. So for this development work, we used 9,606 cases of cardiac devices as our development sample. So the next part is where we really tried to develop, validate, and then improve the performance of all of these different flags. And just like we did with the antimicrobial work, we started by getting clinician expertise to identify a set of text strings that could be used in the clinical note to document a cardiac device infection. We applied those text string searches to the population that had this positive flag based on what I had just shown in the previous slide. We didn't want to apply it to all 9,600 because that we wanted to try to get as close as we could to people who really had an infection. Then we did a blinded review, chart review of a sample of cases that had positive and negative text string flags. And once we were in there, again, like in the previous study, we did a lot of kind of information from the clinical note to try to understand why the case had been flagged by that text string or not. Then we looked at the sensitivity, specificity of the algorithm. Because once we did this chart review, we were able to see if the patient had an infection or not. So then we were starting to get our own gold standard chart review data from this much bigger set of cardiac devices, so much bigger than the CART EP data we had worked with previously. If we felt like the flags were working pretty well, we would move forward in developing the full algorithm that took into account all the different diagnostic and therapeutic data from our previous study. And if not, we would look for the reasons that things didn't work out from that chart review result. And then we would, again, go through this step of adjusting the algorithm. And that almost always was just about the TIU notes, since those were the things that were different from our previous work with the CART data. And then go through the whole thing again with another set of blinded chart reviews and building up. In the process, we were able to build up more gold standard chart review data which made it easier and easier for us to kind of measure the sensitivity and specificity of the algorithm. I think in the end, we actually went through about 4 iterations of this blinded chart review. So let me show you what happened when we got into the, the beginning toward the end of this TIU note text string search. So we started with all the keywords that are here in this table, and we ended up rejecting the keywords here and keeping these keywords. And there are lots of different ways that a cardiac device infection can be described. I am not a clinician, so it was kind of new to me that people describe things as like a pocket, like that's the spot that the device went into. Also things like the lead and other, this is again highlighting how important it is to have clinician expertise and to not try to do something entirely with a team of informaticists, but really make sure that you're talking to people who are familiar with how the procedures work, how the infections work. So we realized that a lot of what mattered was to use multiple keywords, so 2 keywords, and make sure that they were relatively close together. So we did a lot of back and forth about, do we have 20 spaces in between? Do we have 3? Do we have 1? How far apart do these 2 things need to be to make us feel pretty comfortable? And I do want to highlight that there were a few places where we just tried to use 1 word, but obviously you'll see in our final list, 2 words were better. We looked really carefully to see not just how often the keyword flagged a real infection from our chart review work, but also how often the keyword flagged in general. So if the keyword was flagging in 20, 30% of our cases, but we know that the infection rate in cardiac devices is lower than 20%. That made us pause and think that probably we weren't getting as precise a flag as we wanted. We also noticed that symptoms were infrequently documented, or they were really present because that was something the clinician was saying, checked for abscess, for example, right? Checked for dehiscence. So there were some descriptive things, also the warmth, tenderness, that kind of thing, where it would show up, but it would show up not just because it was present, but because they checked. And then the other thing too is with micro, a lot of these things, MRSA, MSSA, staph, these are all micro keywords that we thought would help because we thought they would be looking for that when they searched for an infection. But it turns out that there's just such prevalent MRSA screening in hospitals that a lot of times we were seeing that just because it was a routine screening process and had nothing to do with an infection. So we ended up with this final list. We also realized as we were doing our circling around our iterative attempt to make our algorithm perform better, we realized a couple of different barriers or challenges, and we came up with different solutions. So again, there's this documentation of prevention strategies that we solved by using a couple of keywords, but making sure that the documentation was occurring after discharge. So what we would try to do is limit the search to at least 3 days after the procedure itself, because sometimes there would be, and again, this is actually the same thing here, right? Documentation of signs and symptoms of a post-procedure infection, and we realized we needed to really start our surveillance after the discharge, because what would be happening is that before the patient was sent home, they would instruct the patient, if you see, redness at the site, then you should call us. But that would be written into a clinical note. So we realized, okay, we have to postpone when we start. So start later. The other thing is this issue of a prior cardiac device infection. And honestly, I'm really proud of this. This might be my favorite thing that we did. We decided to create 2 flags. One, if all of those keywords showed up 3 days after the procedure, or if all those keywords showed up before the procedure, indicating that there was a history of infection. Because again, if a patient has a history of an infection, that's going to get documented by the clinicians going forward, because that puts the patient at higher risk of a future infection, and the providers want to know that. but it means that all the same keywords are going to show up, and that's going to create a lot of false positives for us. So we added this second history of TIU note flag. And then, of course, we have this problem. What if there's a lot of clinical note documentation that we can't access? If they were managed in a hospital outside of the VA, for example, which can happen if you have an infection and you go to a local emergency room, eventually you're going to get transferred to the VA if it's an inpatient problem. But a lot of the initial documentation might never make it to the VA. However, we used a lot of other variables. And so if the patient was eventually transferred to the VA, we would capture their antimicrobial use, we would have a diagnosis code, that kind of thing. All right, so I want to show you, this is, if you go to our paper about this in JAMA Open, you can see the full table of how our, like the individual predictive value for each of the variables. So all of that other stuff that you saw in the previous slide that Westyn showed when we used the CART EP data set, there's very similar predictive value in this study. But this is new, so I wanted to show just these two rows so you can really focus on them. So just as a, we had the 9,606 cases in our sample for development. We did chart review on 381 of those cases and found an infection in 47. So about 12% of them did. Again, we only chart review cases. This shows up in a lot of work I do with adverse event detection. 12% is not the rate of infection in the VA for cardiac devices. 12% is from our sample, which had a higher likelihood because we did some previous work to only include people who had some structured flags that indicated an infection. So this isn't the true rate. Of those people, 30 of them died. Only 7 of the people who died had an infection though. So this is how our algorithms performed. You can see that, 7% were flagged for an infection. And of the patients who were flagged with our post-procedure infection flag from the keyword search in the TIU note, 95.7% of those people had a true infection. So we were dancing around the room when this result came out. This is really exciting. Then when we added our infection history flag, that flagged a lot less often. But again, you can see that it's sort of occurring commonly in both of the people who had an infection and overall, right? So what we're really happy to see though is that this number, this 10 out of 47 was not higher. We don't think, by the way, just again, you can have a history and that does kind of predispose you to a future infection. So we didn't expect this number to be 0, but we were really pleased when we saw this. All right, so what we ended up doing next, this is our algorithm to find an adverse event or an infection after these cardiac devices, okay? So we knew how each variable worked on its own, and then we put the whole thing together in a logistic regression model predicting an infection. And again, we had these 381 chart reviewed procedures as our gold standard data set with 47 true infections. So we iteratively tested different combinations of the predictive variables, and that includes these structured diagnostic and therapeutic variables, as well as our new TIU note data. And this is the final algorithm. So you can see some of these are similar. It's similar to what we had done with the CART data set. But as you can see, our C statistic was actually very high. We got very close to finding the true cases. The things that ended up mattering, right? If the patient died, that was pretty predictive. If they had some prior comorbidities, if they had an infection diagnosis code. Also, if they had some antibiotics that were indicated for staff, that was important. And we had to include, have a reference group, so we had to include all the antibiotics. If they had a micro order specifically for cardiac, the cardiac area, that was very important. But really the most important one of all is if they had this TIU note documentation of an infection. That was huge. That was hugely predictive. And history of infection was also significantly a negative predictor. So all of these things work together to create our algorithm. And then the next thing that we did is take this algorithm and apply it to our 9,606 validation cases. And then of those cases, we did chart review on about 3/4 of the ones that were flagged the high likelihood of infection, and then 1/4 that were flagged with a very low rate, so that we could make sure that we were getting a sort of potential for negative and positive cases. And we saw, again, like a very high C statistic, and a lot of the same variables were still significant when we looked at our validation data set. This next slide is just showing the performance again. What we emphasized when we did our iterative modeling was a high sensitivity and a high specificity. And we got a very high sensitivity and a moderate specificity. You can see, again, these are the ROC curves. It's sort of like what I just described before, that, you know, the development was a little better than the validation, but both of them were very good. What we decided when we looked at our chart review results with the algorithm performance is that if the predicted probability of an infection was over 10%, then we would say that those cases were the cases that may have had an infection. That was sort of the threshold that we set. And at that level, the positive predicted validity was 41%. So this, again, would never be something that would be used as a standalone quality or outcome metric. This is a way for us to dig further into the data with chart review to confirm true cases. But very few of these cases had a high probability or had a probability over 10%. So it dramatically reduces chart review burden if you're trying to target the identification of infection. And again, you can see that the probability in our validation sample, when you had a probability greater than 10% with our algorithm, the PPV was 43.5%. So it was very comparable. So what did we learn from this process? Well, TIU notes are useful, but there are challenges. And one of the biggest is just we don't know what is actually not in the medical record that was still done to the patient. So if they didn't document it, we'll never know. The other problem is that sometimes parts of the note are pasted. So you see, again, this historical problem showing up over and over. There's the data access issue where some facilities are not pushing their clinical note data into the TIU table in the CDW. That seems to be resolving, and I hope it will get better with Cerner implementation. Also, scanned notes are not always searchable in the TIU table. Sometimes parts of the clinical note are not searchable, so that can be very confusing because you see the clinical note, but if you were to run a text string, it can't find the things that have been pasted into the note. It's really confusing, and we just discovered this when we were doing chart review, that it shows up in the chart review when you open the note, but you can't find it with a text search of the TIU because it turns out that it's paste, it's a PDF. So that is a problem. And then there are linkage issues where sometimes the visit SID on the TIU note doesn't match the visit SID for the procedure you're interested in. And similarly, the date of the note doesn't match the date of the procedure. So finding the notes that are really relevant for that procedure can sometimes be difficult. And at this point, I'm going to turn it over to Westyn.
Thank you, Hillary. And we do have a little bit more as we move forward on implementation. So I'm more than happy to talk about the next steps, but I also want to encourage you guys, I know we're getting to the top of the hour, to put in questions. And if you want to ask specifically about the TIU notes, we're happy to address those Hillary, maybe you can have a look at some of the questions as I begin to talk about the next steps. So some lessons that we have learned. One, a combination of structured data, such as orders and dispensing data, and text note searches may be a useful strategy for expanding quality measurement to outpatient and procedural areas. These strategies have a high level of accuracy across the majority of the healthcare system, and they are attractive because they can really limit the amount of human time needed to perform chart review. Limitations of this approach are primarily due to facility-level documentation practices, and in the future, we may need to look at standardized note entry or facility-specific and adapted algorithms to solve challenges prior to a widespread implementation and dissemination. So now we've told you about how we develop these tools and why we develop these tools, but how can we now take these tools and leverage them to improve real-world clinical practice? Because that's what we want to be able to take the informatics and translate them to improve bedside clinical care. So this is our algorithms overlaid across the entire VA healthcare system among facilities that perform greater than 50 cardiac device procedures per year. And so you can see this is the number of device procedures performed in the facility. And then this is the percentage of procedures with postoperative antibiotics prescribed. And this line down here is the proportion of procedures that had a greater, these are all of the greater than 10% predictive probability of infections, so an approximate infection rate. As we described, it's not perfect and manual review is required, but about at least half of these are true infections. And what you can see from this graph is showing you another way. There really is no correlation between infection rate and postoperative antimicrobial use. But we can use this tool to measure both. And so then how can we take this measurement and use it to actually improve practice? So now that we know what's going on, we can find infections and we can measure appropriate guideline concordant care. How can we use that information to begin to improve practice at the bedside? So in order to begin to take these data and to translate them into real bedside clinical care, we conducted qualitative interviews with electrophysiology providers across the country, and we gathered data about what drives their current practice. We also sought input on what would make them change practice, and we then mapped these responses from the qualitative interviews to evidence-based implementation strategies to develop a de-implementation plan and to hopefully reduce inappropriate antimicrobial use, reduce antibiotic-associated adverse events, and improve care. So when we spoke to the providers, what we found is that they have a strong desire to optimize outcomes, and that they have a lot of respect for local content experts and opinion leaders, and they're also really motivated by the strength of the data. So these factors are things that we can leverage to improve care. So the fact that they want to optimize outcomes, we linked that to feedback about both infections and non-cardiac outcomes, such as kidney injuries and C. difficile infections and C. difficile-associated deaths that do impact overall outcome, but may not be coming back to the provider, to the cardiologist who doesn't take care of patients who have C. diff. Engagement of local champions to receive and provide feedback and audit reports. This is an important aspect of engaging local content experts and in leveraging this trust that providers may have amongst each other. And then provider education about the strength of the underlying data. Some barriers to change that we found, including a lack of resources and difficulty monitoring patients and concerns that problems or infections wouldn't be identified. And so in particular, what providers told us was that they're giving antibiotics after the procedure because their impression is that they might help and they don't hurt and they don't know what's happening to their patients. And this is where our automated surveillance system comes in. We can now give the providers reassurance that we are following the patients and we are going to be looking for infections, and if there's a problem, we will find it. Lack of knowledge about consequences. This includes a broader educational and audit and feedback program, and I'm going to come back to that in a second. And then concern about not providing a standard of care. And so that's part of the reason why we're including practice across the VA and benchmarking and champions, as well as development of local policies and processes to reassure the provider that if they don't provide the antibiotics, they aren't doing anything wrong. So how can we leverage these surveillance systems to improve practice? Based on our qualitative interviews, we put together, based on qualitative interviews, and I should say implementation science theory, we put together this general model about what happens following a cardiac device infection or device implantation, and what we might be able to do to change practice. So somebody comes in and
Westyn,
has a cardiac device implantation, and let's say they have a cardiac adverse event, such as a hematoma or an infection or a device failure. The electrophysiologist or the provider who's in charge of that cardiac device receives feedback about that adverse event, and then that provider takes an action to reduce that adverse event in the future. And in particular, the action that they take is to provide longer antibiotic prescriptions following the procedure in order to reduce this loop. However, that in turn increases adverse events related to antibiotics and guideline-discordant antibiotic use, including AKI and C. diff. But these conditions are actually taken care of by different providers. They're taken care of by hospitalists or primary care doctors or nephrologists or gastroenterologists. And so the electrophysiologist never finds out about the adverse events that occurred due to the antibiotics. They only hear about the adverse events related to the cardiac device. And so without any feedback, there's no change in practice, and the longer antibiotic prescriptions continue. And so
Westyn,
one of the concepts
sorry, Dr. Branch-Elliman. Dr. Mull is trying to break in.
Sorry,
sure.
Westyn, we should probably stop now, and since it's 2,
Okay.
and just give people a chance to ask any questions that they might have, because I know there are some that have come up from the chat. But I think
Okay.
we're ending at 2, so we should probably stop.
All right, I will wrap up then.
Okay.
And so the idea is that if we put this all together as part of a broader program measuring antibiotics, measuring infections, and then also beginning to include some of these other adverse events, we may be able to alleviate this gap in knowledge that contributes to ongoing unnecessary antimicrobial use. So at that point, I will skip my last slide, and we just have a lot of people to thank, including our study team, our mentors, the VA Boston Center for Healthcare Organization and Implementation Research, as well as all of our funders. And we'd be happy to take any questions.
I think Hillary actually answered most of the questions that came in, all the questions that came in through the Q&A. There's a couple things that came in through the chat. Let's see. Did you consider using tools? No, Hillary, you answered that one. How did you adjust for the negative, i.e. no evidence of ICD infection?
Well, in that case, I mean, I think the problem with that is just that's an unknown to us. If we can't find it in the chart review, which is our gold standard data source for whether or not there was an infection, then we assume that there is no infection.
And then there's somebody asked something about scan notes being PDF files, and I think that's similar to the CSV question from earlier. And that's
Yeah,
it.
and I should have been more cautious calling that a PDF because I'm not exactly sure what it is. All I know is that it's not scannable right now with the TIU search option that has been developed. So it could be a picture. I know that you can scan PDFs. So I'm not sure what's going on there. That's a new development that we were just made aware of.
Thank you. Unfortunately, we have run over, and that was the last of the questions. So if you would like to make quick closing comments, now would be the time, and then I'll wrap up.
So I guess the only closing comment that I have is that we are fortunate enough to have received VA EHR funding, and we are going to be slowly moving this from evidence into implementation, and we do hope to disseminate our tool in the coming years. And so we are very excited. If anyone is interested in leveraging this and using this data, please do reach out. And if you have any questions, please also reach out to us because we're very excited about this technology and we're happy to share it with all of you. And Hillary, do you have anything to add?
No, I'm really pleased we were able to present. I'm apologizing for going over. I think I talked too much in my part, but it was great. Thank you.
Well, anybody can reach out. Your emails are displayed right now. So attendees, write those down, and if you have any other questions. But also, when I close the webinar momentarily, you will be presented with a short survey. Please do take a few moments to provide answers to those questions. We appreciate them. And with that, I'll just wish everyone a good day. Bye now.